This is T9.
Yeah, D9.
T9. 10, 11,
Yeah.
9, 8, 7.
Yeah.
So
Yeah.
this is all in the region of the thoracic spine.
Yeah.
The thoracic spine,
Is already fixed because of ribs.
right. So if we fix it from 7 to 11,
11, yeah.
you will not feel a real limitation of your motion.
Yeah.
Yeah, but you need it to get a real stable
Spine.
spine.
Mm.
If you do less,
Maybe
it's risky.
Yeah.
Yeah, and this you already have now. So risky.
I have risky already.
Yeah.
Yeah.
So okay. So as we do it, we start from posterior. We remove the screws here.
Yeah.
We insert new screws.
With MIS again or
No, I will do
big
it.
incision?
Big incision. So it makes no sense now to make compromises. Yeah, it's you will feel there is no difference because we have to see if
the root,
if the connection of the facet joints.
Facet joint, yeah.
If it's
rigid or
yes.
Rigid or
And if it's rigid, then we have to
cut it. Yeah.
And to compress posteriorly.
So it will not give me pain after, because facet joint is always making pain for me if it's rigid.
Yeah.
Right?
Yeah. And it gives us the option, because a kyphosis is always the result of posterior destruction and anterior compression. If you do an operation, then we have to do the contrary. So we have to make a little bit compression posteriorly and distraction anteriorly, and then we can get a real good restoration of the spinal profile. Yeah?
Yeah.
So, insertion of screws posteriorly.
Not one big incision in the middle or in on the each screw, because I have already incisions.
I know. Yeah. But now we would
but
like
now
to
I
do it
should
in the
you
right
should
way.
see the facet joint. You have to
Yes. Yeah.
cause
And you will see it's not a big problem for you.
yeah.
Yeah. And
Because I saw the operation of opening in mid, they are moving everything right and left to see the spine, a clear spine. So I think they are making a big pain after the
big
operation.
pain or big destruction. No, we just have to, how to say, die Muskulatur, wir schieben die Muskulatur von den
Yeah, you take the muscles right and the muscles left.
بس العضلة حيبعدها شوية عن
until we have the right insertion point for the screws.
Yeah.
So,
and after that you have to come from
and then
anterior.
Wait a second. And then when we have inserted the screws, we already put in the rods, but we don't fix the rods. We close the skin. We
From
turn-
posterior,
Yeah.
you put the rods from posterior. The how you put the roots from posterior after taking this out in the same position?
No. Just let me explain. I have a plan.
Yeah.
Yeah, because I did it several times.
Yeah.
So we insert the screws. We insert the rods. But the rods are not fixed, but they are already in. We close the skin. This is in a position where you are in a prone position. Prone position. So the posterior construct is then almost finished. still loose.
Yeah.
And then you will be turned
My side.
on your side, and then we do the thoracoscopically
Yeah.
part of anterior, cutting the anterior ligament,
Yeah.
and now we put some compression posteriorly, distraction anteriorly, and put in the cage.
Yeah.
And then we fix everything.
Everything. So the roots are fixed interiorly,
No,
from
posterior.
posterior
Mhm.
also. I will feel it because I feel the roots always when I sleep on my back and like this.
Yeah, we have to try to use flat ones, but it's not possible to work without rods, rods and screws.
And because I saw some operations they are fixing from interior from lateral
Yeah,
interiorly.
yeah.
It's not available on my case.
We need both.
Mm.
We need the cage anteriorly and the screws
Because I saw
posteriorly.
there is a system one piece blade.
Yeah.
It's coming to the all the vertebrae together
Mm.
with maybe 4 or 6 screws.
Mm.
I don't know if this is available or not.
Available is everything, but I don't do it. So,
Ah.
just to say, I have some experience with this technique. I propose, and so there is no negotiation about.
Yeah.
Yeah. So if you come in my hospital and we should do this, then we do it as I tell you,
Yeah.
because I'm convinced that this is the best for you.
Okay.
I saw many constructions,
Mm.
yeah, and I wouldn't do any compromise, yeah, because the result alone counts for you. And now you all already have a bed
Approach.
construct here, and if you do the next one, so you don't have so many chances. Yeah, the next one should be a good one.
Yeah.
Professor, jag har en bemärkning.
Ja.
Det fattar om flera av grabbarna inom genom att
Kein Problem. Ich habe da kein Problem.
Aber nur der Junge selber, weil er hatte schlechte Erfahrung gehabt, deswegen ist er immer skeptisch und er
Ja.
ist nicht ganz, auch mit der Psyche, nicht ganz stabil.
Yeah, and he also knows a lot. Yeah, he read a lot in the internet, and so he is almost a spine surgeon. Yeah, and I fully understand him, but I'm now doing this for 25 years, and I was not always here. I worked in a trauma center in the south in Murnau, so we did a lot of these cases, and this was what we figured out is the best for the patient, even if it is now a little bit more open surgery. So everybody does minimally invasive and percutaneous screw insertion and so. But here it's not important. Important is the result. Yeah. And so
The pain. The important.
The
The pain. I want to
yes.
take the
And-
pain away.
And
That's
as,
all.
and as long as you have also a micro instability, if there is something moving, you will keep the pain. When it's really stable, the pain goes away.
I don't have to worry about the screws that is inserted from back. Because I always feel the pain when I sit and put my back on chair, rigid chair or something.
But now these screws make this
Yeah, moving.
moving, and this makes pain.
Gut,
Okay.
dann brauchen wir einen Termin für die OP. Ja. Dann müsste